Management of malignant tumors presents big problems, and there are no promising success in this area. And if malignant tumor arises on the skull base, it produces even more complicated situations due to involvement of critical structures in this area. Mainly, malignant tumors of the skull base can be represented by three types of lesions. The first group of tumors originates from various tissues of the skull base, like chordomas and chondrosarcomas, and others can invite into this region as an extension of head and neck cancer and metastasis of distant cancer. Treatment of skull base tumors represents a great challenge because of their anatomical localization. The standard treatment protocol for primary malignancies include surgical resection, radiation therapy, using different techniques, and chemotherapy. But radical surgical resection of these tumors usually is not possible despite recent advanced microsurgery and skull base techniques. However, complete resection is still challenging because of a lot of surrounding critical structures. Conventional fractionated radiotherapy is indicated in the case, of course, in the case of head and neck cancer, due to radiobiological advantages of this method for this type of tumor and their infiltrative manner of growth. But radiosurgery and hyperfractionation may be a primary radiation treatment for skull base metastasis, chordomas, and chondrosarcomas. And in addition, these techniques are reasonable for re-irradiation of recurrent head and neck cancer. The main principles of the work of our center is to practice radiosurgical paradigm. Radiosurgery is a very precise delivery of high-dose radiation to the target, which is very accurately localized. It can be a single procedure or several stages, but in all cases, it uses high-dose radiation delivery by principles of stereotaxy. Visualization of the target is the key to ensure the further treatment procedure to be correctly. Therefore, radiosurgical treatment requires high quality imaging. MRI is used for visualization and localization of the tumor, as well as surrounding anatomical structures. CT is used to demonstrate local bond instructions, and fusion CT and MRI may provide additional anatomic information. High resolution MRI, T2, T1, axial, coronal, and sagittal planes, contrast enhancement images, and their fusion with CT are used for precise localization of the tumor and critical structures. 3D reconstruction may help to estimate the position, shape and size of the tumor and its relations with the surrounding structures. Radiosurgical treatment requires a high degree of conformity, so high doses should be concentrated within the target with a steep dose fall-off outside the target in order to maximum protect surrounding structures. The first will be primary skull-based tumors, chordomas and chordosarcomas. They are quite rare and present less than 1% of all intracranial lesions. Their biological behavior and clinical prognosis differ significantly. Chordomas, which are malignant primary bone tumors, and they are the most common extradural cleval tumors, and chondrosarcomas, which can be low grade, but also can be malignant. Clinical presentation of these tumors are not specific and depends, of course, of their anatomical localization. The imaging features of chordomas and chondrosarcomas are similar, and they appear hyper-intensive on T2 sequences and heterogeneous on T1 with inhomogeneous contrast enhancement. And these characteristics can suspect the presence of these tumors, but of course histological determination is necessary. The current standard of initial treatment is surgical resection. In many cases, it required multidisciplinary approach. And the preferred initial management strategy for skull-based chordomas is generally maximum tumor resection followed by high-dose radiation. In all the serious conventional radiotherapy with doses from 50 to 60 gray demonstrate poor local control between 17 to 23% after 5 years. And the possible reason is that these tumors are radioresistant. And then nowadays, stereotactic high-dose delivery is used for hyperfunctionation or radiosurgical modalities. A multi-institutional study evaluated relatively long-term results of 71 patients with histologically confirmed skull-based chordomas treated with SRS. And the study shows the efficacy of radiosurgery of these radioresistant tumors, and as well as low complicated rate. Another study shows that gamma knife radiosurgery is an effective therapeutic option as an adjuvant treatment following resection in selected patients with chondrosarcomas. Radiosurgery provides high level of local control. This is an example of patients with chordoma invading the cavernous sinus, and the diagnosis was defined by biopsy, and radiosurgery was performed with the Lexel gamma knife 4C. Multiple isotopes were used to create a conformal treatment plan. The prescription dose was 16 gray at 50%. And this slide shows the result after 2 years, and it is possible to see a shrinkage of the tumor. And the next slide presents the results of CyberKnife treatment for skull base chordoma 2 months after partial resection. And follow-up MRI examination under 1 year also show shrinkage of tumor. And the next example of recurrent chordoma treated with hyperfiltration and MRI 5 years follow-up revealed stable disease. The next topic which I'm going to cover will be metastasis of cancer to the skull base. In the general practice of most radiosurgeons, brain metastasis account for half of their entire activity, and however, skull base metastases are not so common. It is considered that skull base metastasis from distant tumors occurs in 4% of cancer patients. The type of primary cancer is also differ considerable from brain metastasis. Very well that lung, breast cancer and malignant melanoma have predisposition to spread into the brain. But this paper demonstrated a literature review of nearly 300 patients with skull base metastasis provided by a group of authors from France. It was shown that distribution of these pathologies differ from a well-known distribution of brain metastasis. The most frequent are metastases from prostate cancer in men, and breast carcinoma was leading in women. Skull base metastasis may be clinically silent, and clinical manifestations also depend from their site. Nowadays, MRI is the best method to detect skull base metastasis, but other methods also helps to confirm this diagnosis. Due to difficult localization, surgical removal do not usually use for management of these tumors. Radiation treatment can be applied in standard radiation regime. A classic schedule of 30 gray in 10 fractions. But it can it can produce regression of symptoms, but not provide good local control, especially in the cases of radio-resistant tumors. Stereotactic high-dose radiation can be applied in the form of radiosurgery and hyperfractionation. This paper analyzed the clinical results of radiation treatment, and it was shown that neurological improvement is affected by the timing of the treatment. The complications of stereotactic radiosurgery for skull base region have been reported to be new cranial nerves neuropathy, cerebrospinal fluid leakage, and hemorrhage from the carotid artery, probably due to tumor reduction. This is a clinical case of breast cancer skull metastasis. MRI revealed metastatic lesion growth in the left posterior fossa, and the caudal cranial nerves and left carotid artery were involved into the tumor. And the treatment was performed with gamma knife in a stage radiosurgical mode. Multiple isocenters were used. And the MRI in dynamics demonstrates progressive tumor shrinkage within several months. And then tumor completely disappeared and remained controlled 5 years after radiosurgical treatment. And this is another example of breast cancer metastasis in the skull base. MRI revealed a big lesion occupied the left cavernous sinus. And gamma knife radiosurgery was performed in 3 sections. 10 gray at 50% isodose line, 1 fraction in 10 days. And 6 months after radiosurgery, the tumor significantly decreased in size, and tumor control was observed for 2 years after gamma knife treatment. And the next topic which I'm going to cover is the use of stereotactic high-dose radiation for treatment of local failure of head and neck cancers. Surgical resection, of course, not in many cases not possible in these cases, and re-irradiation using conventional radiation therapy is associated with poor outcome and incidence later complications. The use of SRS for recurrent head and neck cancer firstly was described by Dr. Konziolka and Lansford, and a more recent study showed that they showed good outcome, and they concluded that SRS is an acceptable option for previously irradiated patients. This slide shows an example of cyber knife treatment for nasopharyngeal carcinoma recurrence, and this tumor almost completely disappeared in 1 year following irradiation. Another example of nasopharyngeal carcinoma failure after standard treatment. And this tumor invades into the left cavernous sinus. Gamma knife radiosurgery was applied within a marginal dose of 16 gray. And 3 months after the treatment, MRI revealed tumor shrinkage, and no evidence of tumor growth was observed for 4 years after treatment. However, in 5 years after gamma knife, MRI showed local progression of the tumor. And this is another case. Patient had a recurrence of nasopharyngeal carcinoma after surgery and conventional radiotherapy. This tumor occupied the left cavernous sinus and was very close to the optic pathways. And the carotid artery goes through the tumor. Radiosurgery was performed in 3 sessions with a prescription dose of 7 gray. And 3 months after the treatment, the tumor shrunk considerably, and MRI 70 months after treatment revealed no evidence of the tumor. And the tumor shrinkage caused the complete recovery of neurological deficit. And in conclusion, skull-base malignancies are not very common in the radiosurgical practice. The key of success treatment is the advanced imaging, conformal planning without any margins, and accurate dose delivery. The risk of complications increases in the cases of history of previous radiation. Hyperfractionation is preferable in the cases of involvement of critical structures. Thank you very much for your attention.